It will not. Copy.
Hello, Juha. I can't hear you. You're mute. You're mute, Juha. You're muted.
Okay, now I'm
Hey,
here.
Yeah, how you doing, Juha?
I'm fine. I'm fine. Hard day, but now
Oh, very good.
well prepared.
You know, Ben is lecturing now in Egypt.
Who?
Ben yeah, he's lecturing at another conference now.
Oh.
Yeah, no, I'm sure he'll be here. But let me show you. Maybe I can get him here.
Yeah, he's.
Just give me a second here.
But he has a webinar with
Yeah,
Egypt.
yeah.
Oh, yeah. I noted. Yes. But he's
Yeah, let me
with the translation.
let me show you. There he is. So he's a busy man,
Yeah. But he loves it.
and plus he's translating too.
Hmm?
Wow, he's got a busy schedule.
He loves to be involved everywhere now.
Yeah. You know, I just have to learn WeChat. The media is different than anything. You know, I've got to study it. It would be nice if your hospital had a WeChat person. You know what I mean? They could help Ben. You think your hospital?
Don't understand. Do you understand what he means?
He wants to learn WeChat.
Yeah, I bet you someone on your staff, you know, that speaks English could teach me WeChat.
Juha can do it.
Yeah. When you have when you have time. When you have time later, we'll arrange for some time. Okay.
No problem.
Great. Hey, can you type your email address or send it? You know, Juha, send it to me, please. Okay.
He's involved in all emails I sent to you.
Yeah. That's good because obviously WeChat.
I will send you an email then.
Okay.
I will send you an email then.
Perfect.
Yeah.
Perfect. because there must be some, on Facebook, there are a lot of neurosurgical groups. So we put the announcement there. I'm sure in China, there are websites where you put announcements of,
Yeah,
what's going on in neurosurgery.
Yeah, there's a neurosurgical page in China. So
Yeah, that's the biggest neurosurgery announcement in China platform.
Yeah, I know of that Metion. I know of that site. But there has to be others too, many others. So, hopefully we'll start one.
In China, we announce everything via WeChat. So I think
I know. Here it's like Facebook, LinkedIn, sometimes Twitter, other, but China just WeChat, right?
Yeah. And we can watch the videos via WeChat.
Oh, okay.
And
Now,
that-
are you a resident?
Yes, I'm a resident in the hospital.
Okay,
And I'm a postgraduate
okay.
in
he's
neurosurgery.
working with me.
Well,
in my office.
I got some books on WeChat, but I like to, just talk a little time, not a lot of time.
Yeah.
And you can
Okay,
send me
useless.
links. Whatever.
I will teach you some basic functions, which is useful for us. No, don't need to look at that books. Let's use this.
Oh, okay, throw it away, huh? Well, you use WeChat all day long, right? You pay your bills and you
everything.
banking and
Yeah, in China with WeChat and Alipay, you can do everything.
Yeah, okay. Yeah, well, what does someone do without a phone there? You must be dead. I mean, you can't do anything.
You are
Wow.
right. You're right.
People don't want to take cash.
No, we don't take cash, but we must take our phones.
Oh yeah, that's a terrible thing to lose power. I've lost my phone and was paralyzed. So I couldn't do anything. Couldn't log into anything. But I'm sure it's even worse with WeChat. Okay, I'll be back in a few minutes. Okay.
Okay, thank you.
Yeah.
We hope Tubin is coming also.
Good evening, Professor Juha.
Good evening. How are we doing?
It's Muhammad from Bandung.
Yeah, from Bandung?
Yeah, Muhammad. I saved my hair, so
Okay. So that's why I couldn't recognize.
yeah. Actually, my wife did my hair because of the pandemic.
But it's cheaper.
How are you?
We are fine here. Of course, now when you cannot travel at all, so it is like a little bit restricted. So, for example, here in Zhengzhou, we are not allowed to go. Hospital workers are not allowed to go outside of the city.
Oh, yeah.
They're very, very strict orders here in China.
Yeah, of course. Actually, I'm here with Selfie, but she's doing something right now. She'll be joining soon.
So, where are you working now?
I'm now at the National Brain Center with Selfie. Yeah, with Selfie.
In Jakarta.
Yeah. Yeah, in Jakarta.
Okay. It's busy place.
Sorry?
It's busy place, big hospital.
It's always always even during the pandemic, the surgery is still going
Yeah.
on a lot. It's actually my first day. I come to Jakarta yesterday, so today is first day, and we are doing some emergency surgery, FIPI shunt.
And how is the weather in Jakarta? Hot weather, raining.
The
How is
pandemic?
the weather?
Oh, the weather? No, it's now it's not raining right now. It's very hot and humid. Not very nice.
35, 40.
Uh, around 35. But when it's
35.
rain, it'll be flooding everywhere. It's not nice also. I think if we talk about the weather, Bandung is nice. It's better.
Yeah, because it's higher, so it's the temperature. Oh my goodness. Very sure. Got the last minute video. How many minutes now?
Copy to the.
We come back a few minutes later. We come
Yeah.
back.
I have to work on my presentation. I got a new video, so we have to install it.
Hey, you want to test something?
Sure.
We just put a new video in my presentation.
We come back.
Oh,
We come back a few minutes later.
Okay, you don't need to do anything now? That's not.
Professor will take some.
Juha, we may wait a few minutes because Ben is still talking in Egypt. Okay, we're gonna wait a few minutes, okay?
5 minutes.
Yeah, let's wait because I can see he's still presenting. He obviously can't translate unless he's here, so.
Is there someone? But then it is not good if we don't have translation. We should have a translation.
Oh, you have one there?
No. We should have Subin to translate.
Yeah, so we wait for him then, right?
But this Egypt times they're very fluent. They don't hold the times
Oh,
in
really?
Egypt.
No, I think I don't think he has much time because he's been presenting for a while. I think he's almost done.
Where is that now? There? No.
I'm sure no one minds waiting a few minutes.
LXR.
Hello, Noor. And Selfie's here, Mohammed. Hi, Selfie. You there?
What's the video?
Noor's there.
Where's the video?
Maybe can you play on this desk?
No. Where is the video? We have some time now to find because Subin is late. No, but it should be on the desktop.
Yeah, I know, but
What's
maybe
her name?
this one
Okay.
or the XR, right?
LIXR.
Yeah. Just show me where it is so I can enter.
Open file location.
Huh?
Open our location. It's on the top.
Where?
The physical copy.
What is the name? Lixer.
Yeah.
It's on the desktop.
Yeah, but where?
刚才说的在那个还在盘上吗？
I'm gonna put the bit on there.
因此在这里
You can
是吧
see them.
This one?
That's
There's the-
live. Ben is speaking.
Tell me where is the video here?
能快去剪接一下。
What is that? What was this that? Oh. Oh. Ah, now it's fucking still.
啊，加油！
Can you hear his presentation?
This that. Now we are disconnected. Close the program.
Let me try. Hello, Louis. Buenos dias.
Let now Juha to do. Otherwise we lose the game. Yeah, but I don't
Add it to the presentation.
close it, so I will do it. Close it. Close, close. I open my presentation and then I can do it.
Okay.
Desktop.
Okay, he's giving the take-home messages now. So I think he's wrapping up. Good morning, Victor. Buenos dias de Mexico. Victor, unmute, unmute.
Buenos días. Muy buenos días.
Oh, buenos días. Hay muchos latinos aquí. Luis,
Buenos días.
Victor, hay otro latino también.
Running, okay? Yeah, it's
Okay, he's finishing now.
Okay, now.
Okay, so hopefully just be a minute or two.
First away.
I hope there's no questions.
Good morning, Juha.
Okay, now I put down.
Do you see Louis, Juha?
No, go down. Yes.
Okay. Return to 11.
Okay, thank you, thank you. Okay.
Anybody watching, we're waiting for
Half
Ben
an
to
hour.
finish
Sure.
another presentation in a conference based in Egypt. And we're actually watching him. He's wrapping up now.
Hello, Luis. Hello, Victor.
Hello.
Hello, hello. Hello, Victor. Okay, thank you, thank you. So now we are waiting for Subin.
Yeah, he's finishing up.
When he's ready, then we can go with.
Yeah, okay, whatever you want, you are. If you want to start, just let me know.
I don't want to start because Chinese people close the presentation. if
Yeah,
it's
okay.
not-
I think if we just wait, he'll
Yeah, we
be
have to
here.
wait for Subin. Otherwise,
Okay, excellent, great. We'll wait for him. We'll wait for him.
10,000 people.
Right, we'll wait for him. Fine. I'm gonna watch him right now on the silver screen.
Yeah, but
He's answering questions now, so.
I could begin to give my lecture. I'm totally ready, but I know when it is not translated in Chinese, 10,000 people are disappearing. You understand?
Yeah. What, you want to start now in English?
No, no, I don't want to start without
Okay.
translation.
Okay,
It is
that's no problem. We just wait.
extremely important.
Okay.
Otherwise we lose the game.
Yeah,
Totally.
I understand. That's fine.
Yeah.
Dr. Aaron Musara.
Hello, Dr. Juha. How are you doing?
Hello? I'm okay. I'm okay. So
Yeah.
I operated today very big AVM grade 4. So we had
Wow.
a hard day and now.
Good.
So, as it was freak. So I hope Egyptians let Subin free.
Yeah, I'm going to put Ben on the screen here so we can watch him. He's wrapping up his questions.
Okay, thank you. Thank you. Thank you.
I go home and I can see.
Okay, of course, of course. Thank you. Thank you.
Can you hear that?
Transarterial embolization of direct carotid cavernous fistula high coils.
Okay, Ben is here. Okay.
Okay, then it's great.
Yeah, he's here. He's here. Okay.
Where?
Excellent.
Subin, yeah. If he is able to translate, then I will begin immediately.
Okay. Hello, are you there, Ben?
I'm ready.
Okay, Ben, you're a busy guy. Thank you very much.
Yeah.
Okay.
Sorry, because I have another webinar with.
I know, we were watching you.
Yeah. Okay.
We were watching you in Egypt.
Thank you. Yes.
Okay,
yes.
okay.
Okay.
Okay, ready to start, Juha?
I'm ready.
Okay,
Let's go.
10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach, home of Neurosurgical TV. Welcome to Juha's Neurosurgical Grand Rounds of August 7th, and especially welcome to the Chinese neurosurgery community, Fun Yi Nei. Fun Yi Nei. Okay, I'll introduce Juha. Okay, Juha, it's all yours.
Hello, everybody. Ni hao. So I will speak now about surgery for proximal internal carotid artery aneurysms. Once more, now working in Zhengzhou, Henan Provincial People's Hospital. And this is the background for all these presentations on aneurysms. I have been working in 2 centers in Finland last 18 years. Until 2015, I was chairman in Helsinki, and before that in Kuopio 17 years. And we have good databases on these big number of aneurysms, 17,000 patients with 22,000 aneurysms. And now we speak about internal carotid artery aneurysms. So in this database, there are around 4,000 internal carotid aneurysms with good follow-ups and clinical data. And I like always to show some historical things. So I know that the first angiography was done in Finland 1939, just before the Second World War. And I have old video from that time of techniques. So I will show how the aneurysms were diagnosed that time. I show once more this very short video. So I have done also during my residency more than 200 of these angiographies in trauma cases. We had to do angiography with direct puncture. And of course, the techniques of neurosurgery were in earlier times rather primitive, have developed extremely much. So these pictures are from 1953. You see a big aneurysm with silk ligature and Oliver-Krona clip. But now we come to our subject, proximal internal carotid artery aneurysms. I mean, these are aneurysms which are in close proximity of ophthalmic artery. So they are close to the skull base and close to the ophthalmic artery. There are many different classifications, but this one is simple to understand. So these are from our database, more than 22,000 aneurysms. So number of internal carotid artery aneurysms is 20%, 1/5. So the middle cerebral artery aneurysms, like mentioned in earlier presentations, were the most common arteries. But so 1/5 of these aneurysms are in internal carotid artery, and this means more than 4,000 cases. So to speak about these proximal internal carotid artery aneurysms, they are partially hidden by the skull base and many times bilateral, mainly on the left side, and there is strong female predominance. My teacher, late Professor Dr. Drake, was speaking about female aneurysms. and they may grow in large or giant sizes. And because at least when they are very big size or inburied in skull base, so there is high management morbidity and mortality. So they are difficult to treat, except in experienced hands, and even in experienced hands, they might produce difficulties. So there's one special group of proximal internal carotid artery aneurysms. They are intracavernous aneurysms. If these aneurysms are small, they are innocent. In our material, there are around 500 patients with long-time follow-up, and nothing happens to these patients. So they should not be treated. I think, and I'm sure it is big malpractice to treat with different endovascular means, or even in earlier times to treat them with surgery, because they don't harm the patients, because they cannot bleed in subarachnoid space. So I once repeat, intracavernous small aneurysms should not be treated by endovascular means or by microsurgery. Pioneers like Vinkodolens were operating on these aneurysms. Can you hear me? Can you hear me?
Yes, we can hear you.
Okay. Vinkodolens, pioneer of intracavernous surgery, he ligated these aneurysms, and I have seen him to do it. But has some interfere now.
Okay.
Some disturbing dogs.
Okay.
So once more, they should not be treated, but they are treated. The doctor should know that they are innocent, and you should not push something inside arteries when there is intracavernous small aneurysm. Once more, intracavernous aneurysms, if they are small, they are innocent. If they are large or symptomatic, this is completely different thing. But if they are small, don't treat them. This is malpractice. So now coming to proximal internal carotid artery aneurysms. So for microsurgery, good quality CT angio is the best diagnostic method, because when you are operating on these aneurysms, we have to see the relation of the skull base and aneurysms. For microsurgeons, DSA pictures are floating in heaven. You don't see the skull base, so you have no idea how everything goes. So CT angio, good quality CT angio is the best diagnostic method in proximal and many other aneurysms. To do good CT angio, if you have a good system, you can have excellent pictures in 10 minutes. But good CT angio needs big devotion and skills. So you have to have special interest for that. And if you are doing only DSA, you are usually not skillful in doing CT angio. But when doing microsurgery of aneurysms in skull base, you need CT angio, and this is very important. We have done in Helsinki since 2000 very few DSAs because all aneurysms were operated with CT angio. In the proximal internal carotid artery aneurysms, anterior clinorectomy is necessary in most cases, and you should have proximal control, and you can do it in many ways. In earlier times, we dissected cervical carotid artery, put a rubber sling around it, and then close the carotid artery when bleeding began or it was needed. I have tried also balloon, but I stopped to use balloon, proximal balloon control, because I had 3 carotid dissections with balloon. And of course, this is a terrible thing when it happens. So I came finally to a solution that I explore with splenectomy, intracavernous carotid artery. And this is very special place because here in China, there are extremely heavy atherosclerosis, that this part of carotid artery has very seldom atherosclerosis, and you can put temporary clip there. You will see that in the videos coming. So the surgical strategy, there are elective unruptured aneurysms, then you have acute ruptured aneurysms, you have emergency aneurysms with large intracerebral hematomas, and then you have large, giant, fusiform aneurysms where you have to do very advanced approaches. And once more, no treatment for intracavernous small aneurysms, or then some aneurysms in advanced age. You have to know that the rupture rate of unruptured aneurysm is 1.3% a year. And if the patient is 75 years and has maybe 5 or 10 years time left, so the risk of rupture is very low and the risk of treatment is by far higher. So the planning, we have to know how is the patient grade. There are different gradings. Botterer was one of the first. Dr. Drake was using it, and then came very Hunt and Hess, and World Federation Neurosurgical grading is very similar to Botterer because Dr. Drake was behind that. Then we have to know the patient age, if there is intracerebral hematoma, size of the aneurysm, which type of aneurysm, ruptured, unruptured, and then the wall of the aneurysm. If there are calcifications, this we can see in CT and CT angio, and if there are parent vessels close to the aneurysm. Surgical strategy, how to place the head elevated clearly above the cardiac level, slightly rotated, and I tilt the head anteriorly to have a good access and visualization of the anterior clinoid process, and I change the head position frequently, especially take the head higher to see better down on the anterior clinoid process. So this is the craniotomy I have shown many times and done since 80s in thousands and thousands of cases. Very simple craniotomy, lateral supraorbital craniotomy, minimal shaving, don't take the hair of the people, preparation of short incision, local anesthetic infiltration with lidocaine, adrenaline, and then single layer flap means there is no or extremely little temporal muscle atrophy and no frontal fascial branch injury. This is important. This is important. You will see in the videos. And how to go to these proximal carotid aneurysms. You creep slowly with forceps and sucker subfrontally. If the brain is tight, then you have to go to basal systems or lamina terminalis to have room. I use water dissection. I inject with my hand to slow down my fast surgery. With water dissection, you can separate many structures. And then, of course, sharp dissection, not blunt dissection. under high magnification of the microscope. If you have red angry swollen brain, and this is often when you are doing acute surgery, then you have to change it to slack brain. And how it happens? Good neuroanesthesia with mannitol and intravenous anesthesia. You can do ventriculostomy. I have done very few ventriculostomies because I go through small subfrontal space to lamina terminalis and basal cisterns, even to Liljeqvist membrane, and suck slowly CSF out. This is the most important thing in acute annulus surgery, to make space, to have a slack brain. Then you can do miracles in your surgery. And this is a recent case. We just cut this video. We did maybe 3 weeks ago. Ruptured left-sided ophthalmic aneurysm, rather complex looking. This is after bleeding. And these are the pictures. We were wondering how the aneurysm is located. Now this is the opening, and you see that there is a very severe subarachnoid hemorrhage. And now we creep down and suck CSF.
The video is not running.
Video is not running.
No, it's only stopping the CT.
Yeah, just restart it.
Can we restart it?
Yeah.
Is it running?
It's
Is it
going
running?
now. Yes, it's running now.
Okay, so there's a big discussion how to do anterior clinoidectomy. I do intradurally. And I have my reasons. I will come back to that. But here we go do clinoidectomy. And you see that it is very, now I have intracavernous carotid artery. I put temporary clip there. Situation was difficult and difficult to understand here. This is the diamond drill. This fresh subarachnoid hemorrhage. So now I have this peculiar looking aneurysm here. I put pilot clip there. And the golden clip is in intracavernous carotid artery. Now there's pilot clip, and now we should have better clip. It is not occluding totally the aneurysm. I put again temporary clips, and now I coagulate the aneurysm down and change the clips, and now take the temporary clip from intracavernous carotid artery. It looks confusing now. It looks very confusing. I take muscle and put on the clinoidectomy place. I hope in the next, I fill the clinoidectomy space with muscle and clay. And this was the video. So we go to the next one. So we will see better tactics. This is ICG, and the patient made good recovery, even had very severe subarachnoid hemorrhage. So we go the next case from Helsinki. Edited by Juha. This left unruptured paraclinoid carotid aneurysm. Patient had earlier surgery for other side, and in unruptured aneurysms, you can see better the surgical techniques. This is a very small aneurysm. This is the short incision for lateral supraorbital approach. Please note, no shaving. And now opening here. Going to basal systems and releasing CSF. And now, why I do intradurally the clinoidectomy? Because I can tailor it. I don't have to take so much. Sometimes the smallest clinoidectomy is to coagulate the dura on the anterior clinoid. This gives 1 or 2 millimeter space, and it happens here. Now, drilling some part of the periclinoid. I have used also sonopet, but we had 3 blind eyes with sonopet, so it is nice to use, but I think it might be dangerous for the optic nerve. So now, very limited, tailored anterior clinoidectomy, temporary clip on the proximal carotid, golden color is good. And then checking the situation now. Usually I put on both sides of the aneurysm temporary clips. Now here, I just coagulate down the aneurysm protected by the temporary clip and coagulate down the base. And put the clip on the base of the aneurysm and take the temporary clip out. And you have to be very careful when taking temporary clip out, because you might feel relieved that now the aneurysm is done. It's just to take the temporary clip out, and it might be different location. And now we put papaverine and to release vasospasm and glue. And this is the situation after surgery, and now you have on both sides the clips because the patient had earlier surgery. Next video. This is left ruptured paraclinoid aneurysm. You see the subarachnoid hemorrhage, fresh subarachnoid hemorrhage, and rather small aneurysm. As mentioned, we were using only CT angio in Helsinki for surgeries. You see, it is 4 millimeter aneurysm, ruptured, and again the same opening, no minimal shaving. This is minimal invasive surgery, is minimal shaving, and here fresh subarachnoid hemorrhage. Most patients were operated on in the first days. Again, going down basally, dissecting here optic nerve, and then behind optic nerve you have the lamina terminalis. I go with my microschissors or sharp forceps there and release CSF, and here is opening of the Liljeqvist membrane. And now I coagulate the dura on the anterior clinoid and make detach dura and then take the diamond drill and take a look. This is a big diamond drill. Big diamond drill in the beginning is very safe in anterior clinoidectomy. And I'm missing here very much this big diamond drill. I hear today that these diamond drills are used 2 years here. This is nonsense because they lose their capacity. I think the reason that for that is that the seniors are not opening, so the younger neurosurgeons have to suffer with the poor instruments. So now cutting the dura, tailored, very tailored approach again here, and now we didn't take so much out of anterior clinoid, this temporary clip, and now we put also on the other side, distal to the aneurysm, golden colored temporary clip, and the aneurysm is pointing to the left in this screen. And now dissecting the aneurysm, very thin walled, press rupture. And then putting clip, definitive clip is here told. I doubt that my first clip is definitive, but now removing carefully the temporary clip because the clip handles may be attached or close to each other, so you have to be very slow and careful in that. And now checking the situation. Now the clip is in place, so I usually coagulate down the aneurysm. We made also a lot of research by cutting the aneurysms before coagulation for basic research. And this is the ICG after clipping, so patent carotid artery, and of course the aneurysm cannot fill because it is coagulated down and main part is cut. And this is the situation after surgery, slack brain, postoperative images, and good outcome of the patient. Next case is here. This is a contralateral approach. Next week, Hugo and Rade will make a throughout presentation, but I wanted for special reasons to take this case because I made contralateral clinoidectomy in this case, and this is I have done extremely seldom. Again, standard approach. In 10 minutes, you are down. And it doesn't take so much time if the instruments are proper. So this is the anatomy. And now I go to the other side, contralateral side, coagulate dura and drill contralateral clinoid out partially, tailored, because maybe it was a mistake to do this aneurysm from contralateral approach. You see the left ophthalmic artery there, and labeled the different structures, and then I put the clip. And when you do contralateral surgery, so of course you have no proximal control. So I put the clip around the aneurysm, and then we give adenosine. There is cardiac arrest, and when there is cardiac arrest, then I close the clip. I wait, clip open for cardiac arrest, and when it is cardiac arrest, then I close the clip. And now checking. In this case, I'm playing maybe too much because I'm not happy with the clips. I put second clip. This is double clipping because the lower clip, proximal clip, is taking the base totally, because the first clip is pushing the proximal one down. But I'm correcting now. I don't know why I'm playing so much here, but because it looks also dangerous, because the clips handles are close to each other, but I had a very special thin clip appliers, so I can play more with them than with rough clip appliers. Now its situation is dangerous because the clips are attached to each other. So yeah. Why he's doing that? Why he's doing that? Sometimes you should be happy with 90% good result, not try to have 100% good result. But now I'm clipping and clipping. Crazy surgeon. Now I had a good clip, and now I put one more down to have all the base taken. Yeah, it looks dangerous game, but now there are clips, and the aneurysm was well clipped, and the patient made good recovery. But maybe in this case, contralateral approach was not right selection, because I had to do clinoidectomy there. Hugo Andrade will speak next week about that. And then we come again, edited by Juha, who made huge number of these videos. This left ruptured paraclinoid aneurysm, severe subarachnoid hemorrhage. And again, very small aneurysm. Main part of the ruptured aneurysms are less than 7 millimeter. These are the CT angios, and again, short incision, and you see the state of brain, red, angry, swollen brain. And now this is water dissection. I dissect with water because water is tender, more tender than instruments. I inject water, distending the subarachnoid space, and in this way, now I release CSF. Slowly, this is the most important thing in neurosurgery, to have a slack brain. Then you can do everything when the brain is slack. But if you just put your spatulas on the frontal and temporal lobe and compress them, then you have terrible brain injuries and swelling during the surgery. Again, doing intradural clinoidectomy, anterior clinoidectomy with drill. As mentioned, I have used also sonopet. It is very nice to use. Drilling needs very much concentration in the operation room. should be no noise when you are drilling around carotid artery or the aneurysm. I remember in Shanghai I was operating invited by Xubin, aneurysm embedded inside anterior clinoid, and this was very tedious drilling, but I had a good team there, my own team, and of course good team from Xubin clinic, and we could do very well drill anterior clinoid around the aneurysm away. So now I changed the clip position because the clip was taking the ophthalmic artery. So you have to take care of the ophthalmic artery in this proximal carotid artery aneurysms. Sometimes you can close ophthalmic artery, but not always. You are lucky. The patient might have blind eye from that. And now again, double clip technique. First clip and then the second one, and then taking temporary clip from intracavernous carotid artery away, and then Doppler checking. This is very good method. This is very good. I think this Japanese very thin ultrasound. Doppler checking, and now again the operator is not happy with the clips, changing the clip position several times, pushing deeper, and these are the post-op CT. Next case, they repeat a little bit and the anatomy is difficult. So if you see a video, 5 minutes video, you cannot know everything. This is right unruptured paraclinoid aneurysm. In unruptured aneurysms, like mentioned, it is anatomy is so very clear and you can learn better to do surgery. So this is again lateral supraorbital approach with Sukita hooks retracting. They have make very strong retraction. And then one burr hole, I place it here, detaching dura, and you see how good craniotome is working. Today we had terrible difficulties in the operation room. If craniotome is not taken care and the plates are not changed, so it is big disaster to do craniotomy. And cleaning the field, opening the dura, and the flap is big enough. Flap should be, you should not compete how small the flap can be. I have seen that somebody is writing that his or her flap is 37 millimeter. This is nonsense. The flap should be safe for the patient, for the surgeon, and for the instruments and for the light to come inside. So if you try to compete with the craniotomy flap, you have to remember that the endovasculars are doing 5 millimeter incision to go to the arteries. I have seen late Professor Bernetsky to do always through 1 inch craniotomy, whatever surgeries, but this is not safe. Surgery is not sports because the patient is paying. For me, 4-centimeter flap is good because I'm experienced that when you are younger neurosurgeon, you should do bigger flaps. So here, this was a rather limited heterosectomy. If you go extra, okay, now you see clip weighting adenosine. We stop the heart. I'm waiting with the clip around the aneurysm, and when there's cardiac arrest, then I close the clip. Now coming back, return of cardiac activity. This is adenosine, what we have been using in around 200 cases, but here in China, I didn't get this. It's very useful in doing anal surgery, and it's very cheap medication. Okay, there's still some interesting case. This is a giant paraclinoid aneurysm. This is very special because you see very terrible complication. You don't see the aneurysm, it is 4-centimeter aneurysm, and I'm making clinoidectomy here, and then what happens, I open the aneurysm, and there's a lot of blood. I use Kusa and take now careful look. I'm shaking the aneurysm. It was older man, more than 75 around atherosclerotic vessels, and I'm shaking the aneurysm, taking thrombus out, and then suddenly what happens? It's temporary clip, and then in intracavernous carotid, and now take a look now. Now I'm, oh, you see, the base of the aneurysm is broken from carotid. You see, I was distending too much. You see, there's several holes now. How to do, what to do in this situation? You cannot go away. So I took muscle, put the muscle on this place, and then clipped, sealed the hole with the clips. This is the first clip, second clip. So they clip, the clips are going around the base of the aneurysm, and the muscle is compressed on the rent which I caused in the surgery. And now I took temporary clips out. This is the intracavernous temporary clip, and check with Doppler, and put one more clip to hold the muscle on the place at the rent. And then ICG was there, and the patient recovered fortunately very well, except this terrible complication. Terrible complication. I showed this, that you see there are many things you can do, also in terrible situation. And then there is maybe one more video. This is unruptured giant. This is terrible aneurysm. This is terrible aneurysm. Huge aneurysm. So, like golf ball, buried inside. I always position the patient myself, and because I think how the aneurysm is located. And here again, a simple approach, even it is huge aneurysm. This is A1, and soon you will see how strong the aneurysm is pulsating. So now I put temporary clip. And here I estimated wrong. And now again, adenosine. But adenosine, and then I go inside. And there's of course no return. A lot of blood is coming, but it was so big aneurysm. So even it was totally isolated, so a lot of blood was coming. It looked so that there is a big bleeding. And now I put the T-bar clip and check the aneurysm. And because it was thin-walled aneurysm, so I coagulated down. But you will see that I estimated the base wrong. So I have to do clinoidectomy to have totally the aneurysm occluded. So this is ICG, doesn't look good. So I have to do something because you will see that I will do clinoidectomy here, okay? Clinoidectomy is done here. And then I go put 2 temporary clips on intracavernous carotid, and then I have to add more strong clips to have all the aneurysm clipped, ring clips. And yeah, now it looks better. Thin-walled aneurysms are better because you can coagulate them down. If they have strong wall, they are more difficult to treat. And if they have thrombus inside, then extremely difficult to treat because they are more dangerous than non-thrombosed aneurysms. So these are postoperative images, good, and the patient made, with this long row of clips, made good recovery. But of course, this was a very difficult aneurysms. So I will come back to the anterior clinoidectomy. This is extra or intradural. This is cocktail party discussion. This is one of the discussions. Are you doing clinoidectomy extradurally or intradurally? I do intradurally. Why? Because 20 years ago, I had a ruptured aneurysm. I went extradurally and the aneurysm ruptured during that, and I was in a terrible situation. I couldn't manage that, so I began to go intradurally so that I have all the situation under my eyes. I think you should do clinoidectomy that way you are used. Dr. Drake said always, and I certainly agree that you should use the same approaches because you know the anatomy. I do intradurally, and one of the advantages of intradural clinoidectomy is that you can tailor the resection. Just take as little as possible or as much as needed, and we have also published this paper maybe 10 years ago with Dr. Romani. And finally, few things. To be highest level of neurosurgeon, you have to have good skills in surgery and in English. This is very important in international neurosurgery to be able to speak English. And one more final thing, don't shave the beautiful Chinese hair. You see here some examples. Don't take that. Of course, the people don't want to have craniotomies if you make them bald. Take the beautiful hair out. Make focused minimal invasive haircut like you saw in my videos. This is Chinese practice nearly all over. Take a look on this 10 years old girl. She had a large hematoma and AVM, and this is a few days after surgery. And she was very happy to have her hair, like most females are happy, because it takes at least 1 year. You are social when you make patients bald. And this is one example of subgroup of the patients, how we have been treating very low level cases. You see, if you treat unconscious patients, grade 4, 5, then you have many deaths, but you have also patients which recover like miracle. I think we should be medical doctors to try to help the patients. Don't count how much is our mortality. And one more thing, to open the head is not dangerous. It is our profession, at least as neurosurgeons. Those who tell differently should not call themselves neurosurgeons. And those who are opening the head in a dangerous way should stop their activities, do something else, psychiatry or neurology or endovascular. So, extremely important, you are not operating alone in the operation room. You need a good team. This is our team here in Henan Provincial People's Hospital. Good team doing proper microsurgery. So I thank you very much. Sei ni. Kiitos.
Okay, Juha, thank you very much. Great. Okay, I'm going to turn it over to Hugo Andre, the neurosurgeon from Henan that you work with. Fun Yi Nei, Hugo.
Hello. Hi, Professor. That was a
Hello, Hugo.
good to
Hello,
see.
sorry that I showed one contralateral approach, but I wanted to show that it was wrong selection.
Yeah.
So Hugo will speak next week about contralateral approach. Hugo made his PhD on contralateral approaches, and very good PhD book.
Yeah. So it was a good talk, and like always, a lot of experience. There's few participants. They have questions. I'm just gonna ask you something very quickly. Is how do we had already this talk before, but how do you find the internal carotid artery into the cavernous sinus? How do you identify the proximal control there?
Yeah, it is not so easy and difficult to show in the videos, in the short videos. I make clinorectomy. I think I begin the clinorectomy laterally. And sometimes when you drill then medially and then you shake the anterior clinoid so you can draw it out. But there are many different clinoids. There was some publication that you should always take it out with wronger. But I don't think so. It might be dangerous. Yesterday or 2 days ago, we made an aneurysm that was just ruptured and very close to the anterior clinoid. So I was in the evening, I was using 1 hour for the clinorectomy because I was all the time afraid that the annulus rupture because the patient had cerebral sclerosis, so I couldn't have any proximal control. So how to find? You have to study the anatomy, and Doppler is very useful.
Yeah.
Mini Doppler is very useful.
Okay, I think Professor Mohammed Fahmy wants to ask you something.
Hello, this is Professor Fahmi Zaid from Alexandria, Egypt.
Hello.
I need to ask about drilling of the anteroclinoid process. I understand from your talk that you prefer to make the drilling intradurally. That's right?
Yes.
Okay.
I told.
Okay, go ahead. Professor Fahmi Zaid from Alexandria, Egypt. Hello?
Yeah. I cannot hear you.
The point is that I see a lot of surgeon, maybe a colleague or a senior colleague, prefer to do the drilling of the anteroclinoid process extradurally. I understand that there would be a little bit technically difficult to make the drilling extradural because you have to do a good stripping of the dura from the anteroclinoid process, especially if you have a pathology like the paraclinoid aneurysm there. So why you prefer to do intradurally? However, the extradural drilling make protection of that aneurysm wall by a double layer of dura from the tip of your instrument which you are making drilling in. Okay?
I thought I had a good slide to explain why I'm going intradurally. I have my historical reasons. I told 10, 20 years ago, I had a complication with extradural approach. Then I decided I will go intradurally. And if you see the people to doing extradural approach, they make a small look intradurally at the end of the crinoidectomy. So it is, they are sneaking inside. So I think this is cocktail discussion. Why are you going in extradurally or intradurally? You have to do safe surgery. For me, it is the safest way to go intradurally. It has no disadvantages. And you have to understand that the anterior crinoidectomy is not a simple procedure. It has also complications. Deaths, even deaths with meningitis, blind eyes, and so on. So if I go intradurally, I can tailor the approach. The smallest anterior crinoidectomy is to coagulate the dura on the anterior crinoid, and then different grades. We have published with Dr. Romani that maybe 10 years ago, tailored anterior crinoidectomy. But
okay, regarding the same point again, you show us a case of paraclinoid aneurysm, and in that case, a huge bleeding was happening. I think in that case also, you have already make the drilling of the anteroclinoid intradurally. That's right?
I told since 20 years I have done anterior crinoidectomy intradurally.
Yes.
And
the point, okay.
And
the point, okay.
One more point I want to say, the videos are not, all the complications are not taken away from the videos because they are deductive videos. You can make beautiful videos if you cut all the bleeding out.
You treat that, you treat that particular case which you showed us after a complication of very huge bleeding. I think by putting muscles and then temporary clip proximal, that's right, or what is the steps chronologically after you find this a lot of bleeding after you finish the drilling and of the anteroclinoid process? I mean the steps. You first put the proximal clip, or you first put small pieces of muscles, I understand. Is that correct?
You speak about the complication when I ruptured the annulus base.
Yes, on the paraclinoid, and the paraclinoid portion, especially.
Yeah, it is my principle is to solve the complication. If you are so good that you have no that kind of complication, I will ask you for the next operation to help me.
Okay. Okay. I can come then from Alexandria.
I remember I was in Spain, Zaragoza, to speak about complications of annulus operation, because I have a lot of. Let me tell you, I have a lot of videos, and I showed a lot of different complications. And
of course, yeah.
May I speak now?
All of the neurosurgeons all over the world are facing a lot of complications. That's why this is the importance of international webinar discussion. All of us will face it, but we are trying to understand and educate each other about the least possible complication what we can go through and deal with. Thank you very much. You have a very nice presentation and a very good, I can say, a rare case for huge aneurysm. Thank you.
So I wanted to tell you a story.
Yeah.
In Zaragoza, in Spain, I was 15 years ago to speak about complications in aneurysm surgery. I showed all videos with terrible complications, and then the people in the first and second row, they began to look at each other. Who is this guy speaking? Very poor level surgeon. Yeah,
yes, I understand this is the way of thinking, but actually on the operating theater, this is another story. I know this very well. I have visited so many foreign countries like Germany with Professor Sami, Osama al-Mufti in US, and in Japan, Professor Kawasi. Yes, I know all this complication is happening even with the big giant neurosurgeon. I understand this very well.
Dr. Drake, my
yes,
teacher.
Yeah,
may I speak now? Dr. Drake said, you have to be so honest that it hurts. And of course, it hurts.
Yes, of course. I understand that. I understand that. All of neurosurgeons understand that.
Hello, Professor Juha.
There are many neurosurgeons who have no complications.
Now we continue with the question.
One comment.
Was the Dr. Luis Lopez you want a question, right?
Well, one comment, Juha. I thank you very much for your presentation, Juha, but in my opinion, most of the case is not easy to treat it by endovascular approach. The surgery of the cavernous aneurysm or carotid aneurysm is very hard surgery. I know very well my friend Vinko Lolen. I know very well the technique and the difficulty of the surgery of this type of aneurysm. In this moment, in the world, more than 10,000 or more aneurysms is treated very sample by endovascular approach. I don't discuss with the flow diverter or not flow diverter. I don't discuss that. I discuss the endovascular treatment of this type of aneurysm is real most sampled by neurosurgery. Have a exception case. I have expert neurosurgeon, of course, by Juha or Dolenk or whatever you want, but it's not normal. It's danger. Danger to discuss this is a surgery of this type of aneurysm is feasible for everybody. No, I think cannot. I think it's not. It's in the indication of endovascular endovascular treatment is better for myself.
Okay, thank you. Something more?
Can I ask a question, sir?
Yes.
Yeah, of course, of course.
Yeah, Professor Juha, this is Dr. Altaf Ali. I'm from Karachi, Pakistan. It was really nice talk. I always learn from your talk, and the beauty of your talk is that you are very candid and honest. And as a young neurosurgeon, I feel that we always learn from our seniors and veteran neurosurgeon like you. And your honesty is also a kind of moral thing which you teach by your talks, that we have to be honest to teach juniors. My question was about the use of adenosine to give cardiac arrest. We never do it, and I have never seen it in my training to give a cardiac arrest to patient. So it was a new thing for me today. Have you ever encountered any problem like reverting back from asystole to sinus rhythm?
In one case, in the beginning of around 200 patients, there was one old lady who had some kind of a cardiac disease, and we had difficulties to get her heart beating again, but otherwise it is very no serious complication. It is wonderful method because you can repeat it many times, and especially in small aneurysms where the clip may slip away, then you give adenosine, the heart is stopped, then you close the clip, and then the clip is not slipping. And it is very safe. So in Helsinki, they were so used that it was nothing, just to say give adenosine. I mean, if you have premature rupture, then you give adenosine. Then you have around close to 1 minute time to find the rent and seal the aneurysm. It's a wonderful method. But I'm sorry I couldn't get adenosine here for some reasons here in China in use. I have to ask once more. It is very cheap and very safe. Very safe. You should not use it in old cardiac or pulmonary sick patients, but in regular patients you can use it. Extremely safe and repeat many times.
Right, sir. Thank you, sir.
Yeah. Another.
Thank you. Thank you.
Any other questions? No. Okay. And then I guess we continue with Shubin or Dr. Lopez Iboa.
Yeah. Thank you, Hugo, very much for stepping in at the last minute. Yes, if you want to introduce, I'm going to edit this out, but introduce Ben. Okay.
Yep. So now we'll lead you with Shubin, how Juha calls him the master of the bypasses, or the champion.
World champion.
Yeah. So he will talk about the bypass fluid mechanics principles.
Okay. Okay. Thank you. Thank you, Hugo. We anticipate to listen your presentation next week. So my topic is bypass-related fluid mechanical principles. So for the successful treatment, we should bypass treatment for aneurysms or for moyamoyas. We should know the fluid mechanic principles. The first one is the Poiseuille's law. So Poiseuille's law, Q, this is a Poiseuille's law. Delta P, we can see pi is this pi is pi. It's a fixed number. This is this is a diameter of the vessel, and this is a delta P, and we can see in this Poiseuille's law, delta P is the only motive power for driving the blood flow. So we should make sure to keep the delta P positive. Sometimes the stoma near the high pressure location, especially near the Willis circle, it's dangerous for delayed occlusion of the bypass. So we should select the right position of the recipient artery. Actually, in the moya vasculopathy, there's two kinds of pressure gradient of MCA. This is the first type of the pressure gradient of MCA. Still keeps the physiological direction. So this we can see the MCA network will still shoot from proximal to distal. So this pressure is proximal larger than P distal. But there's another pressure gradient of MCA. Yeah, this is a reversed physiological direction. We can see the MCA was already occluded. The PCAM to PCA was quite large. Then from the PCA to MCA, we can see the M2 was the latest shoot in this angiogram. So this P proximal is less than P distal. So after the bypass, we can see in the flow 800, we can see the red T. So red T means bidirection fast blood flow. It also means a big difference of delta P. So this kind of bypass is sustainable. This is a single bypass in the left picture, and this on the right, it's a double bypass. But sometimes we can see this is a one short arm of red T. We can see the pressure balance point is located in this side. It's only, so this delta P is barely positive. It's only maybe less than 5 millimeters. So just after 1 week in the CTA, we can see the bypass was almost occluded because the delta P is too small. We can see the balance point located just very close to the stoma. So we studied we compared the two pressure gradient of MCA and the bypass direction. So the first in the first pressure gradient of MCA, we the pressure of the proximal is larger than the P distal. This is the second way. And this is the first, if the main blood flow, if the main blood flow flowing in the recipient artery, it's from the higher pressure zone to the low pressure zone. This is we call it the parallel bypass. If it's from the low pressure zone to the high pressure zone, we call it anti-parallel bypass. So this is a result. The conclusion is parallel bypass is better, which means the bypass from the main flow from the bypass to the recipient artery. It's a parallel of the pressure gradients is better. The second common fluid mechanics principles is a Bernoulli's principle. This is a Bernoulli's principle. It's mainly about the blood flow energy loss. In the moya, we can see it's we call it a slope principle. So the flow, this is a Moyamoya syndrome. We can see from the distal part of ICA originated from some Moyamoya vessels, then from the Moyamoya vessels to the M2 segment. So the flow velocity is the largest at the contrasted section, and the increase in flow velocity is accompanied by significant decrease in pressure at the constricted section. So this is a model of the in the lowest picture. We can see this is a fluid mechanicals. So the M1 bloodstream flow through the Moyamoya vessels, then into M2. It's similar to the flow through the restrictor when the beam expanded into a larger area to M2 segment. And then the velocity decreased, pressure increased, but the downstream pressure doesn't fully recover to the upstream M1 pressure due to the greater internal turbulence and the energy consumption. So this is what happened in the Moyamoya vessels. So this is the energy loss. We also can calculate with the different shape of the stoma. So this is a relationship among the diameters, the perimeter, and the cross-section area of fish mouth anastomosis. Because a lot of neurosurgeons, they recommended this fish mouth stoma technique. But we can calculate the resistant coefficient zeta. So this is a calculation of the zeta of the stoma, this fish mouth stoma. We can see in the fish mouth stoma, this is a D3. Actually, it's D3 equal to the D1 to D2. So this is a zeta. This is the greater the ratio of A3 to A1. A3 means this section area to the donor artery A1. So this ratio, the greater the ratio of A3 comparing to A1, the greater the resistant coefficient is. The resistant coefficient zeta is proportional to the square of A3 to A1. So this is an example for bigger ampular part of ICA. This bigger part actually caused additional local energy loss. When the blood flow flew into the common blood flow come from CCA to ICA through the ampular part of the ICA, the blood flow will separated and form a shear layer. This is the blue part, and the shear layer will flow unsteadily and result in irreversible local energy loss. So this is what happened in the fish mouth stoma. The stoma, in my opinion, the stoma should keep oval shape as natural branches. We can see the natural branch shape. It's all oval shape. So our stoma should mimic the natural branches. So this is a relationship among diameter, perimeter, and the cross-section area of ovoid anastomosis. We can see this is the calculation of the zeta in oval shape anastomosis. So under the same conditions, the ratio of A3 to A1 is closer to 1. So the local resistant coefficient zeta is smaller comparing to fish mouth, and the local energy consumption is lower. It's much lower. So this means it's a better shape of the stoma. Actually, the local energy consumption is quite dangerous because, you know, in the aneurysm, it's also because of the local energy consumption, the aneurysm was can getting bigger and bigger, it can growth and rupture. So this is the oval shape stoma's normal sequence of the stage. And after the first stage at toe, there's a last chance to trim the stoma to make it, it in the same size. You can see the total artery and the recipient artery, the stoma shape was all oval. The first stitch is to the toe, then the heel. The square knot is enough. The suture tail should point to the different direction of the two knots. So this can make the square knot. So you can see in less than 6 minutes, the stoma was finished. So all the recipient, the branch of the recipient artery was protected very well. I never sacrificed any recipient, any branch of the recipient artery. So sometimes we can use some small perforator to let some small reflux of the blood flow. This can keep a little bit of pressure in the recipient artery to make the two layers of the recipient artery open. And this can help us in the anastomosing. With the red color of the blood, we can see the recipient artery and the vessel wall, both of the donor and the recipient artery, very clearly. And sometimes, especially in the STA, we can see some sharp bends. It's very common, and we can suppose the STA is taken from point to A to point B. If the connective tissue is cut in the sharp bend, to make it more straight. On the one hand, the local energy loss Hj of the bend can be reduced. On the other hand, the flow can be shortened and the HF reduced. So if you cut the connective tissue at the sharp bend and make the vessel more straight, actually you reduce the angle theta and increase the rate to D. actually this kind of solution can reduce the secondary law and make the blood flow energy loss much less. So this is you can feed the recipient artery with more blood flow. Sometimes, actually, especially the donor artery is much bigger than the recipient artery, so we have some bottleneck of the blood flow. So this is the first way to make the less wasteful of the donor flow. So when the ratio of donor diameter to the recipient diameter is greater than 1.2, so the training capacity of the recipient vessel is less than the maximum blood flow provided by the donor vessel. Normally, it's cut flow. So Q1 actually can it's equal to the sum of Q2 to Q3 to Q4. So Q4 is the increased part, so which is equivalent to the opening another hole in the restrictor, and will reduce energy waste of the donor vessel. So I prefer to use the stoma located along near the bifurcation of the recipient artery. So this can make the recipient artery drain the blood flow more efficiently, like this way. So the bottleneck of the blood flow, how to be less wasteful. The second way is use double barrel bypass with only single branch of STA. Normally, I use a parietal branch. So at the first, I preserve the frontal STA branch, then cut one of the maybe 2 or 3 centimeters from the lung segment, then to make another end-to side to the branch of the recipient, to another branch of the recipient artery. And so this can make the donor artery's blood flow even more. So this is a targeted bypass, should located in the low pressure zone. So this is a single bypass, double bypass, even triple bypass. For double barrel or triple barrel bypass, normally one stoma in the superior trunk territory, one in the inferior trunk territory of MCA. So this is a long-term follow-up. After 7 years bypass, we can see the STA becomes so big, and the blood flow actually not only feeded the whole hemisphere, but also the contralateral frontal lobe. So this is after the revascularization of the whole hemisphere, we can see almost all the hemisphere, almost all the brain was fed by the ECA branches. The 3 layers, middle meningeal artery, STA, deep temporal artery, was all feeding the hemisphere. So this is a blood volume change in Moyer-Weld disease. We can see that bypass, middle meningeal artery, deep temporal artery, and the STA was all increased. In the ICA or basilar artery was all decreased. So this is why we can decrease the hemorrhage rate in the ICA Moyer-Weld vessels and the posterior circulation Moyer-Weld vessels. So this is my take-home message. Understanding the fluid mechanical principle is key to successful bypass surgery, Poiseuille's law, Bernoulli's principle, and the throat principle is very important in bypass surgery. And especially in the moyamoya vasculopathy, there's two types of MCA pressure gradient. So the parallel bypass is better than the antiparallel bypass. Fluid mechanical formula for calculating the resistant coefficient zeta of different stomas shows that the ovoid stoma is better than the fish mouth stoma. And we can make the bypass more efficient if we choose the right position of the recipient artery with more bifurcations. Actually, it can be drain more blood flow into the brain. Okay, thank you.
Okay. Good, Hugo?
Yeah. Bin, that was a great talk and very interested in a little bit complex to understand too.
Yeah.
Yeah,
it's
but
quite complex.
All the principles are important, so then you can guarantee a patent bypass.
Yeah.
Yeah. I don't know if somebody else wants to add something to Bin. Nope. How much is the bypass count now? 7,000?
Yes, 7,000.
Good.
Bin, how, Professor Bin, in your experience, how many cases have long-term restenosis of bypass in your experience?
You mean long-term follow-up, in the long-term follow-up, the stenosis of STA bypass? Yes, some actually, especially in the early stage of the bypass, there's two kind of conditions. One is between the different branches of ECA, the competition between the STA with and other donor arteries like middle meningeal artery and the deep temporal artery. Actually, I always use a combined approach in treat the moyamoya vessels. So in the long-term follow-up, actually, if the middle meningeal artery and deep temporal artery already formed the spontaneous stomas with the cortex, and sometimes this kind of stoma is even more efficient than the STA. So, and it's also changed the pressure gradient of the cortex. So this kind of competition can cause the STA stenosis. This is the first stenosis condition. And the second one is in some complex aneurysm treatment. Sometimes because of the ACAM and PCAM, it also can enlarge after maybe several months. So this is also have some competition with the bypass vessels. So sometimes at just after the surgery, the STA or some bypass surgery, bypass vessel is quite large, enlarged a lot. But after several months, if after the ACAM or PCAM, the blood flow get more and more blood flow from the ACAM and PCAM, so the bypass can be get smaller. So this is a second condition. Because there's always competitions between the same side ECA, different branches, and also some competition between the ACAM and the PCAM vessels.
Good, thank you very much.
Okay, very good. If there's no more questions, we'll move on to the next presentation. Luis Lopez Ibor. How are you today? Luis, just introduce yourself and start on with your presentation, please.
Okay, just a minute. I want to check. I open. And now, second. It's open. And now?
Not yet, not yet.
Is here or no?
No, it's not open yet.
Just a minute.
Okay, you'll get it. You always do.
Okay. It's here.
There you go. Okay. Yeah, there you go.
Okay. Good morning or good afternoon, everybody. Thank you very much, John. Thank you very much, Juha, and Professor Bill. I present some experience of the parent vessel occlusion test to treat the fusiform aneurysm. I don't know why it don't work.
Okay, there it goes.
Yeah. Test occlusion. Why test occlusion with coil and not balloon? Because one case, so many years ago, I have a rupture of the artery with a balloon. I decided in some case it's most safe to put one coil and test anatomical test or clinical test. The truncal aneurysm is originating in a straight vessel, not in the bifurcation. When it's chronic, you are a thrombus, normal. Also, in acute dissecting, it's possible to have a dissecting aneurysm and truncal aneurysm and subarachnoid hemorrhage. And the blister-like also sometimes is the origin of hemorrhagic, and it's very difficult to coil in this blister-like, and you need to close the parent vessel. This is example to 10 patients. It's not proper to use the balloon or a stent or remodeling in this case. 4 aneurysm is a giant anterior circulation and 6 is posterior circulation. Some examples. It's posterior communicant artery in the junction of the basilar tip, giant aneurysm. This is microcatheter. This is the posterior cerebral artery. I decided to push some coils and testing the collateral circulation. Another case, giant basilar aneurysm is treated in 3 times by coiling, and every time is the regrowth the neck of aneurysm, and finally I decide to put in the third session to put coiling and close the artery, the basilar artery in this point. This is the control. You are the basilar trunk, the coil, the collateral circulation here. And this is This is the totally cure of this aneurysm. Another complex aneurysm, distal basilar aneurysm, AP view, lateral view, fusiform. I decided to treat with coiling. I stop the flow, the collateral circulation, and totally occluded without symptoms, major symptoms. Woman, 24-year-old, acutely dissecting aneurysm in E1, is rebleeding 3 months later, and this is the time I perform the embolization. I decide to close aneurysm and E1 and to occlude totally this aneurysm. This is an example that present the last week. It's a 2-year-old child with intraventricular hemorrhagic. I have a fusiform A2 aneurysm. This is AP view, this is oblique view. Sorry, lateral view projection. I decide to put the coil in the neck. I look the stagnation of the contrast. I decide to occlude it, the aneurysm in the neck, and you have the collateral leptomeningeal anastomosis and occluded and 3-month control asymptomatic. Other dissecting aneurysm, 52-year-old, acute hemorrhagic, MR, axial view. This is the dissection, this point. Some of the time, many endovascular techniques discussed to put the stent here. No, I think it's possible. It's not, I prefer the solution to occlude this vessel because this vessel is broke, is dissected. Another aneurysm dissecting in the origin of the pica. I decide to occlude it, and you are with coiling, you are the collateral leptomeningeal anastomosis in the cerebellum without ischemia. This is the first example of the posterior communicant and basilar junction aneurysm, giant. This is the occipital cerebral posterior and occipital artery, AP view. I decide test occlusion with coiling. This is the microcatheter inside the sac. This is the coiling. Only 2 coils. This is a thrombus, and this is the collateral leptomeningeal anastomosis, a total occlusion of the aneurysm. Other fusiform distal aneurysms in the pica, dissecting aneurysm, also is bleed. Navigate. It's better to close this vessel. To use the balloon here is dangerous. It's dangerous. Sorry, the balloon or the stent, because it's very fragile. The wall of the vessel in this part. Only with microcatheters you put some coils. Also another blister-like aneurysm in the superior cerebellar artery, very small with a spasm,
Three or four.
coiling, and occluded aneurysm and protect the patient.
Many evenings.
This is a patient, 70-year-old, with aneurysm with mass effect and bleeding, fusiform or serpentinous aneurysm of the middle cerebral artery. You are here the spasm. You are here the collateral anastomosis. I treated in acute phase in Colombia by myself. I decide to occlude it. This branch, just here, this is the mark. We have the edema around the aneurysm. And the patient is a convulsion, chronic convulsion, and occluded, and the patient is still well. This is a previous study with another doctor with technique, Salupka, Moret, Mawat, Dion, 8 case, 2 case. This is the complication of this series. Many cases have some problems. Transitory, hemianopsia, hemiparesia, facial palsy, dysmetry. Moret and Mawat and Shahrukh Khan did in posterior cerebral aneurysm artery. Is safe to occlude it, the artery. In my experience, I don't have a complication of this pain case, and the result is very, very good to the patient. Thank you.
Carlos, okay, thank you very much. I guess
thank you.
I made the mistake is not unmuting myself. Okay, any comments or questions? Juha, do you have any comments?
Yeah, they look terrible cases, whatever you are doing, extremely difficult cases. So desperate cases need desperate treatment.
Luis?
Yes?
Do you use some monitoring like MEP, SEP when you're testing the coil of the aneurysm?
In posterior or basilar, no. Impossible. It's impossible. And in the side, it's impossible. It's by general anesthesia. The clinical test is, I think, is well when the patient tolerates the clinical test. The electrophysiological test, I don't have many good effects with my neurologist. I don't know why. I don't understand very well. I don't have the experience with you are the neurosurgeon. I think it's very important. Probably it's interesting, but in some case, the only for me is the anatomical collateral analysis with double catheter. You have one catheter inside with treatment, and you have another catheter control the collateral anastomosis.
Okay. So do you have some delayed ischemic condition patients?
No.
No. Okay.
Never. Never. And the patient with the blister, like aneurysm, I don't use the antiaggregation. Yeah, never. This is one of the reasons. In some special case, it's preferable to analyze. It's better to sacrifice the vessel or to put some flow diverter because you integrate the patient. This is the question. The blister light.
Yeah.
Okay, very good. Any more comments, questions from the panelists?
Yes, this is Victor Hugo from Mexico.
Welcome, Victor.
Hello, how are you? Very nice lectures. The rupture of the aneurysm that Juha showed us was impressive, but the most impressive is how you resolve the rupture, putting muscle and the aneurysm. How the patient did, how was the recovery of this patient in the post-operative state, Dr. Juha?
Excellent. Yeah, he made wonderful recovery. Even was old man, 75 or something, with fragile vessels. But, when of course you understand that kind of situation in an operation room, you are dissecting the annulus and suddenly you have 3 holes in the carotid. So the annular space is broken because it was fragile. I have looked many times this video and I didn't put much pressure, but much. So it was good solution. So you have to have that kind of tricks, many kind of tricks. I will show that kind of tricks in future, many, how to manage desperate situations. Of course, sometimes you may lose, sometimes you may do good recoveries. You may save the situation. Just came in my mind. This old trick to use muscle. So I have done it several times in neurosurgery, and muscle is extremely useful in sealing the rents, and you have to just find a way how to put muscle on the bleeding place on the artery. That's I want to show videos which I could show beautifully edited videos without any bleeding and without anything special, but each you have to show how to manage difficulties.
Okay. Really useful, really useful. It's very useful to see how to resolve these big problems. Thank you so much, Professor Juha.
Thank you, Victor.
Okay, more questions, comments from the panelists? Okay, if not, okay, Juha, what do you have anything in mind for next week, Juha?
Next week, same time, welcome. So Hugo will speak about contralateral approach. He made his PhD in Helsinki. And he will speak about MCA and then ophthalmic aneurysm, contralateral approach. I think this and bifurcation aneurysm. So it will be interesting talk. I will show also some videos related to that.
Okay, very good.
Then we continue every week. We continue with different side of aneurysms, speaking now about carotid aneurysm, going upwards up to carotid PCAM, choroid, and then carotid bifurcation, and then we take the next side. So we
Okay.
make special evenings for every site of aneurysms.
Okay, very good. Okay, I'd like to thank Hugo for helping me moderate, and also to Ben, who does translation in Chinese. And I'd like to say welcome to the Chinese medical community. Fun Yi Nei. Okay, Juha, we'll see you next week.
Thank you very much.
Thank you very
Stay
much.
safe,
Bye-bye.
Very good.
Bye bye. Thank you.
Yeah.
Bye-bye.
Yeah. Thanks,
Bye-bye.
Ben. Thank you very much.
Thank you.
Bye-bye.
Thank you.
Oh, Selfie, you made it.
Yeah, thank you for inviting.
Yeah, if I'd like you to meet, I guess Ben probably left. Busy guy, went from one conference to another. Are you in the OR now? Selfie, are you in the OR?
Just finishing, but I'm still on call, so still waiting.
Okay. Oh, okay, very good. I think you guys had Juha. Didn't you have Juha speak at your webinar
Yes.
1 week? Okay.
And we're looking forward for Professor Bingsu for the next webinar this Sunday.
Yes. Oh, great. So we'll see you then.
Yeah.
Okay.
Okay, Juha, thanks a lot, and we'll see you.
Thank you.
Yeah,
Thank you very much.
I just got to study that WeChat,
Yeah.
get to know it well.
Ivan will teach you.
Yes,
I will
please
send
let me
you-
hear from you. Please let me hear from you. It's very important.
No problem.
Okay, see you. Bye-bye. Bye-bye, everybody.
Bye-bye.
Bye.